Hello, everybody, and welcome to the Hughes Clues Student Success Review Session. Today's review session is about acid-base balance and ABG. Pretty much what I'm trying to do with these review sessions is to make the clinical application to you, to use application style questions that are very similar to what you can expect to see on the exam. And with always, I do talk fast. So if you feel like you're getting overwhelmed or the information is jumbling, then just pause the recording and then get caught up and then start it back up again. This slide is basically showing you about that, what I call the ABG grid. This is information that you don't need to memorize, but you should have handy while you're doing this student success session so that you can refer to it. And when we talk about ABG states, we want to know, well, what about abnormal ABG states? What values would we expect to find that would identify each of the four different ABG abnormalities? So when we look at the metabolic acidosis, we know that as defined, acidosis is going to have a pH less than 7.35. And then because this is a metabolic problem, the CO2 should be normal. And because it's a metabolic problem and bicarbonate is ruled by the metabolic system, then the bicarbonate's going to be abnormal. And because this is an acidosis, the bicarbonate value would be low. That is, it would be less than 22. When we're talking about a respiratory acidosis, this acidotic state would be identified by a pH that's less than 7.35. If it's a respiratory acidosis, respiratory system rules CO2, or the lungs rule CO2, so the CO2 would have to be elevated. CO2 is an acid, and so for us, or for the pH to be in the acidic range, then the CO2 would have to be elevated, and that would be greater than 45. And because this is a respiratory problem, bicarbonate would be normal. When we talk about metabolic alkalosis, again, these are just pure abnormal ABG states. An alkalotic state is defined by the pH greater than 7.45. It's a metabolic problem. CO2 should be normal. And then because it is a metabolic problem, we know that the metabolic system rules bicarbonate. If it's an alkalotic state, the bicarbonate value would be elevated, that is greater than 22. Respiratory alkalosis, by definition, an alkalosis is greater than 7.45. CO2 is linked to the respiratory system. For the CO2, an acid, to cause an alkalotic state, it would have to be low, that is less than 35. And then bicarbonate, because it is not linked to the respiratory system, it is linked to the metabolic system, it would be normal. So what's missing? What haven't I identified that defines either a metabolic or a respiratory pH or acid-base imbalance? And hopefully all of you are going, well, where's the O2? And so that's what's missing. And we've identified earlier in the concept discussion, or the discussion of the material in general, that oxygenation should be a separate consideration or a separate diagnosis. And if the patient does have low oxygen levels, the acid-base imbalance that it will cause is going to be a metabolic acidosis. And that is because hypoxia, which is defined as low oxygen in the tissues, will cause an anaerobic metabolism state. So the tissues are not able to produce ATP. The only thing that they can do is produce a small amount of ATP by glycolysis, and this will produce lactic acid, and that will push the patient or the individual into a metabolic acidosis state. Well, what about compensated ABGs? We've talked about compensated ABGs can occur because the body is really always trying to push things back in harmony, back into a normal state. And so the body does have the ability to compensate. So when you have a normal pH, that is what is going to define the potential for an ABG state. And you know that that is definitely a compensated ABG when there is a normal pH with abnormal CO2 and bicarbonate values, as opposed to if you see a normal pH and then the bicarbonate value is normal and the CO2 value is normal, well, then the only thing you can say is that this is a normal ABG. You still will have to address whether there is hypoxemia or excellent oxygenation with your patient. All right, let's look again at some clinical examples. For the most part, Dr. Reed is not going to simply ask you what is the ABG and define it. She is going to ask you the treatment, but we're going to do this step-by-step process, and the first step in that process is to configure what the ABG abnormality is. So what is this ABG abnormality? And when you look at the first value, we can see that 7.35 is a normal pH, but then we see that the CO2 is abnormal. So we know that this is some kind of uncompensated ABG. Now, which system is at fault? We're going to have to determine that in a minute. But we can first of all rule out A and answer C because this is not uncompensated. The pH is in the normal range of 7.35, so we know that this is some kind of compensated abnormal ABG. So this is when we go to the triangle, and we see that if there is a pH of 7.35, that value lands on the left side of the triangle, and therefore we know that this is some kind of compensated acidosis. So then when we next look, we've got to determine which system is at fault, and we can see that the CO2 is elevated and the pH, because we've identified this as an acidotic state, the pH is down, that does fit our mnemonic of Rome, because the respiratory value, the CO2 that is linked to the respiratory system, is up, and the pH is acidotic and therefore down, and so respiratory opposite fits. But let's look at the bicarbonate, and we see that the bicarbonate is increased. So our mnemonic, if this is a metabolic problem, is metabolic is equal. If the bicarbonate value is up and the pH is down, then we do not fit the metabolic equal, and so this cannot be a metabolic problem. So therefore, our diagnosis is going to be a compensated respiratory acidosis, and with a PO2 of 82, again, PaO2 is normal, is in between 80 and 100, is in the normal range. So this is going to be answer B. This is a compensated respiratory acidosis. Be sure and read the rationale if you're still unsure of how I identified this respiratory ABG or this abnormal ABG. Let's talk about the next one. We've got a patient that's admitted to the critical care unit, and essentially what I've done is I've given you the exact same values, but now I've asked you another thing. So we've already configured this ABG, and that's what you need to do first for every question. Configure the ABG. We have said that this is a compensated respiratory acidosis, and then identify, well, what am I being asked about this abnormal ABG. So what are you being asked next? Well, you're being asked what clinical manifestations are expected with compensated respiratory acidosis, and you can select all that apply. So when we look at this, we see that clinical manifestations first are identified as signs and symptoms. So what signs and symptoms would you expect to see in a respiratory acidosis? And we know that respiratory acidosis is linked to CO2 retention, and we can see that the CO2 is retained here because the value is elevated. So what would we see? Well, we would know that there are either shallow respirations, or there are, which is answer A, or there are slow respirations, which is answer A. There could be shallow respirations, that is answer B, because both of those things will cause CO2 retention. Recall that CO2 is removed or exhaled whenever there are deep or rapid breaths, and so that would cause CO2 retention, the slow and shallow respirations. And then when we see alveolar hypoventilation, this might have been a confusing thought to you, but essentially alveolar ventilation is just the amount of fresh air that's entering and leaving. And if there is alveolar hypoventilation, that means that there is CO2 retention because there is less air that is being removed from the alveoli. Deep respirations would not cause CO2 retention, so that is the only incorrect answer. and I try and periodically through my practice questions, I try and list some of these funky or what I call fancy terms because Dr. Reed does use them on the exam, and I don't want you to miss a question because you weren't sure of the definition of a term. So I do try and bring these terms into my practice questions just to get you used to seeing them. What is the priority management of or for a patient who has been diagnosed with respiratory acidosis? There are your options there. Configure what you think is the correct answer. Pause the recording. I'm going to move on. So what is the priority management of respiratory acidosis? Again, what's the priority problem, or what, excuse me, not the priority problem, but what is the cause of respiratory acidosis? And is simply, it is the retention of CO2. So what we want to do is improve alveolar ventilation. In other words, improve the removal of CO2. Now, if you thought about, well, the patient is in an acidotic state, and therefore I should buffer that state, or I should try and get rid of the acidosis with sodium bicarbonate. And that's a good thought because we do want to get rid of the acidosis, but the cause of the respiratory acidosis is a retention of carbon dioxide, and that is a CO2 because CO2 is an acid. And simply giving the patient sodium bicarbonate would, yes, it would bring the pH up, it would bring it closer to a normal or non-acidotic value, but it's not going to do anything about the root cause, which is CO2 retention. So all you're going to do is just change the pH value, and you're not going to change the root cause, which is the CO2 retention. Well, what about improving oxygenation? Probably when you were in your J1 and J2 semesters, pretty much applying oxygen was the stock answer that you were supposed to use. And if this patient was diagnosed with a hypoxemia, and I haven't told you anything about the oxygen status with this patient, all you know is that respiratory acidosis is present. Respiratory acidosis is defined as an individual who retains CO2. You don't know if this patient is hypoxic or not. So the application of oxygen is not going to fix a respiratory acidosis, which is caused by CO2 retention. You have to remove the CO2, and simply applying oxygen is just not going to change the CO2 value. It will only change the O2 value. So that's kind of a trickery and something that you might not be used to seeing. Of course, this patient is not anxious. They're retaining CO2. If they were anxious, they would be removing CO2 at a much more rapid rate. So we talked about this, we need to improve alveolar ventilation. So perhaps you would be given a blood gas with CO2 retention, and then Dr. Reed would ask you, well, what is the treatment for this? And if the treatment is to improve alveolar ventilation, or another way of saying is to get rid of CO2, what would the nursing interventions be? This is a very, very likely question that you're going to expect to see. So what nursing interventions would remove CO2? Well, hopefully the actions that you think about when removing CO2 would be that of turn, cough, and deep breath. So let me give you an example. Let's say this patient had just returned from surgery, and therefore they had been under anesthesia. And of course, anesthesia makes the patient sleepy. Their respiratory effort can be slow and shallow breaths. And if there is a concern with CO2 retention, well, you can ask them to turn, cough, and deep breathe. And of course, this would also improve oxygenation status as well, but it definitely aids in the removal of CO2. So the point for this is don't ever think that just because this is critical care and therefore a critical patient, that doesn't mean that you don't use the standard tried and true methods of the simple, which is what you learned in J1 and J2. Turn, cough, and deep breathe is an option for CO2 retention. Well, respiratory treatment is another option that really isn't a nursing intervention, but it is an option for a bronchodilator to be administered for an action to help with CO2 retention. And we often see bronchodilators given by the respiratory therapist when our patient is a COPD or has chronic emphysema or bronchitis. and these individuals we know to retain CO2. We need to assess pain management. Well, how does that improve alveolar ventilation? Well, we know that if a patient is getting an opioid, such as Dilaudid or morphine or fentanyl for pain management, that if the drug, the opioid, can depress the respiratory centers, which can cause an initial slow and shallow respirations. And so, if the patient has had too much of these opioid narcotics, then we know that we may have to give a reversal agent like Narcan. That's unlikely something that you'll be questioned on in critical care because it's not really in our course, but it is something that you will be questioned on in your ATI or your NCLEX. It is likely a question. What about the use of artificial airways? Well, we know that in patients who have airway management issues, that these individuals can have CO2 retention, and so a nasal trumpet or an oral airway can be used to help facilitate CO2 removal. Suction is another thing. Some patients have problems. Their healthcare problem causes them to have a weak and effective cough, and therefore they cannot remove secretions, and so the nurse may have to go after those secretions by doing a suction. And then the last, of course, if an individual is chronically retaining CO2 and we just can't use these techniques to help with the CO2 retention, then we're going to have to use artificial means, and that's going to be intubation and mechanical ventilation. Now, usually I know students will say, well, do we intubate patients? And no, you don't, but you will prepare the patient for intubation and mechanical ventilation, or you will contact the physician and say, hey, the non-invasive methods are not really working. This patient needs to be intubated. So the nurse can drive the physician to get this patient intubated and mechanically ventilated. What about a patient who has severe dyspnea? Crackles are audible. There's your ABG values. And so what acid-base balance exists? Again, play along with me. If you want to try and configure these on your own, and let's do the ABG configuration first before we do any kind of answering of the question. So the first thing we look at is the pH, and we see that the pH is 7.25. It's definitely less than 7.35. So we know that this is an uncompensated problem, and it's because the pH is less than 7.35. This is an acidosis. So we can definitely rule out answer choices C and D because this is not a compensated problem. Next, we look at the CO2. We see that the CO2 is elevated. This is a elevated CO2. So this could be a respiratory problem, maybe. We'll see. And then we have bicarbonate is decreased. And then we look at back to the CO2, and we see that the CO2 is high and that the pH is down. So we follow our ROME acronym. The respiratory system is opposite. This is a respiratory acidosis. Then we've got to look at the bicarbonate. The bicarbonate is low and the pH is low. So when we look at the low bicarbonate, the low pH, this fits with our mnemonic of metabolic equal. So now we can determine that this is a respiratory acidosis as well as a metabolic acidosis. Hopefully you found this to be pretty easy. Which clinical manifestations are expected in a patient with these ABG values? And really for time consumption, so I don't belabor, we have the ABG values that we've already determined to be a metabolic acidosis and a respiratory acidosis. So what am I asking? I'm asking for the signs and symptoms of an individual in an acidotic state. So this is also, please note, a select all that apply. That means, okay, more than one answer is likely. And for the critical care course, I'm going to tell you that Dr. Reed at this point follows the rules very closely that you should select at least two and never all, and then consider that all options are true or false. Now, and therefore you should only pick the true options. And what about those options that you think maybe? Well, maybe is not true, and therefore maybe is considered false. So if you think maybe, then it's false and don't pick it. So let's look. What are the answers for a patient with acidosis? What would we expect to see the signs and symptoms? And because this patient has both a metabolic and a respiratory acidosis, the causes can be very varied, and so we have to just say, well, what in general are the signs and symptoms of acidosis? And we know that any patient with in an acidotic state can have altered levels of consciousness. So this is where you look at the ABG grid, what I call the ABG grid, and somewhere down in the middle of those 4 identifications of abnormal ABGs are the general signs and symptoms of acidosis. And depressed level of consciousness is one of them, as well as hypotension, because acidosis will cause peripheral vasodilation and therefore hypotension can occur, as well as hyperkalemia. Now, we've talked about hyperkalemia in depth. We talked about the cell buff, the ability of the cell to buffer the acidosis and therefore try and reduce the acid state in the body, and so therefore hydrogen ions will enter the cell, and as a result potassium ions exit the cell and are in the blood. So the answers are A and C. If you have any questions as to why this is the case or it doesn't make sense, then email me. We know that hypocalcemia and tetany, those are associated with alkalosis, and hypertension and hypokalemia are not options because of how we discussed hypotension and hyperkalemia. They're opposite. All right, we've talked about the fact that a patient can have respiratory acidosis. So what illness states or what problems or what diagnoses can cause a respiratory acidosis? And again, to make sure you remember, respiratory acidosis is simply the caused by CO2 retention, and therefore what would cause hypercapnic or CO2 respiratory failure? And the answers to that is myasthenia gravis. This is myasthenia gravis. This is a neuromuscular disease that causes muscle weakness. Muscle weakness includes the muscles of the respiratory that promote respirations. In other words, the individual cannot take a deep breath as well, and so therefore they're weaker respiratory effort, which can lead to CO2 retention when they're having a myasthenia crisis. COPD, we know, causes CO2 retention. A strain or a stroke or a brain attack can cause problems in the respiratory centers in the brain and can lead to CO2 retention. And all of these 3, myasthenia gravis, COPD, and intracranial problems are on exam 1. So all of these problems can lead to CO2 retention and respiratory acidosis. Again, the outlier that does cause CO2 retention is narcotic overdose and hypoventilation. Well, what about metabolic acidosis? What are the causes of metabolic acidosis? And again, because we know that hypoxemic respiratory failure, which means that a patient has low O2 states in the blood and in the tissue, can be caused by pneumonia or ARDS, and all of these hypoxemic respiratory problems, in other words, low O2 state in the blood, can lead to lactic acid production, which will cause a metabolic acidosis. And then renal failure will cause a metabolic acidosis because the kidneys are so important in acid-base balance of removing excess hydrogen ions, holding on to bicarbonate or producing bicarbonate. It's pretty easy to see that renal failure is a key problem in metabolic acidosis, and then DKA will also cause metabolic acidosis because of keto acid production, and that's not really in our course, but you just need to realize that it can occur. A patient is admitted in and their arterial blood gases are as listed. So what acid-base imbalance exists? Again, let's pause the recording, configure the ABG, and then decide what the problem is. And we see straight off that the pH is 7.49. The pH is elevated. It is greater than 7.45. We know this to be an uncompensated alkalosis state. So again, very easy to delete answers C and D. Then we look at the CO2. The CO2 is 42. That's a normal value, so we know that that's respiratory and linked to respiratory system, so that is not a cause of our alkalotic state. And then we have a bicarbonate that is 32. The bicarbonate is high, the pH is high. That gives us the mnemonic of of metabolic equal. So we have a we have a metabolic alkalosis, so that's answer B. And again, for grins, we're going to look at the oxygen status. 95% is considered good or okay, and so we do not have a hypoxemia. So of course the answer is answer B. This is a metabolic alkalosis. A patient is admitted in an arterial blood gases are the same as what we just talked about, so we know this to be a metabolic alkalosis. So let's talk about what are we being asked now about this patient who has a metabolic acidosis. So which finding would the nurse expect to observe as the body compensates? Now we're looking at compensation for the acid-base imbalance. So we know that if this is a metabolic problem, which we've identified this as metabolic alkalosis, we know that compensation, naturally occurring, the body compensating, is going to be done by the opposite system. That's the respiratory system. We know that the respiratory system rules CO2. CO2 is an acid, and we've identified that we're in an alkalotic state. So what would we want to do with acid? Well, we would want to hold on to it. How do we hold on to CO2 and acid? We know that CO2 and acid, to hold on to it, we would want to either slow or have shallow respirations, so the answer is A. And that's why it's so important for you to configure not only the ABG itself, but then once you know that you're being asked about compensation, don't look at the answer options, figure it out on your own like we just did, and then look at the answer options and so, hey, I configured that slow, shallow respirations would be the fix or the compensatory mechanisms for an alkalotic state that's caused by the metabolic system, and so that's how you do this. Otherwise, because of all these options and you're trying to hurry in an exam and you're stressed, you do sometimes pick the opposite. Now also, an even easier route would be to just look on that ABG grid, and it's listed for you there, and you wouldn't even have to think about it. A patient is admitted with arterial blood gases. We've already identified that this is a metabolic acidosis. Now, what are we being asked about this problem? We're asked about what is the treatment. What treatment should the nurse anticipate for this acid-base imbalance? So what is the treatment for a metabolic problem? So the treatment for a metabolic problem is going to be we want to either cause the pH to go up or cause the pH to go down as far as manipulate bicarbonate system. And we see that the options are sodium bicarbonate, calcium carbonate, phosphoric acid, or acetazolamide. And so you would think, well, we're in an alkalotic state, let's give an acid. And so that is not the correct answer. That's not really a drug, phosphoric acid. That's kind of a trickery question. The answer is acetazolamide, and that's Diamox. Again, if you don't want to think, I've listed that on your ABG grid, and you could have just looked and gotten the answer from that. But acetazolamide, because treatment for this problem is to give this drug, acetazolamide or Diamox. That is the answer. We wouldn't want to give sodium bicarbonate, because sodium bicarbonate is a base, that's an alkaline, and we don't want to increase the alkalinity of the pH because we are already in a high enough alkaline pH. Calcium carbonate, that is an antacid, and we don't want to give that. A patient is admitted for an arterial, and the arterial blood gas reveals the following. Of course, we know this to be a metabolic alkalosis. Now let's look and see what we're asked. Acetazolamide, all right, what we learned on the previous slide, or Diamox, which is a carbonic anhydrase inhibitor, is a drug that promotes diuresis, was administered to the patient. So what would best indicate the effectiveness of the medication? Well, there's your options. So what is the problem? Well, you've already identified that the problem is the pH is too high. And the pH is too high because we are holding on to bicarbonate, or we've lost acid and have too much bicarbonate in the blood. So what would we want to do? Well, we would definitely want to lower the pH. We would definitely want to lower the pH. And we would definitely want to remove what is the cause of a metabolic problem, which is too much base or too much bicarbonate. So the only answer that fits the criteria for reducing the pH and reducing the bicarbonate is answer B. So a lot of students will say, well, in the question it was mentioned that this is a diuretic. And it is a diuretic. And so wouldn't the answer of a lot of urine output or an increase in urine output be the potential answer? Well, it is, while increasing the urine output or seeing a lot of urine is an effect of the medication, when you're thinking about if the medication is effective, you really want to know what is the end game. In other words, what is the goal of the drug? What do you want to accomplish for this patient? And what you want to accomplish in the example that I just gave you is that the medication, we want to reduce or decrease the pH to the normal zone, and we want to get rid of the excess bicarbonate. And that's the job of this medication. You are going to often be asked on several of the critical care tests, you've given this drug, how do you know it's effective? And that's what I want you to think of. What is the end game, or what is the goal of treatment of the medication? Dr. Reed does not want you to just regurgitate what the drug does. Dr. Reed wants you to identify that the drug does this, and therefore when I see what it is that I want to accomplish happen, then I know that the drug is working. And so email me if you're confused about that. If you have any questions, again, also email me. I hope this recording has been helpful.